In early May 2026, health officials detected a cluster of severe illnesses in the Democratic Republic of the Congo. Within weeks, imported cases had crossed borders, reaching major urban centers like Kampala, Uganda. The global reaction was swift. On May 16th, the World Health Organization declared the outbreak a public health emergency of international concern. The Africa CDC quickly followed with a continental emergency declaration. This chart tracks the progression of the virus since the index case on April 24th. By early June, the outbreak climbed to 507 confirmed cases and 88 deaths, resulting in a roughly 17% case fatality rate. Global health agencies are heavily focused on these numbers. The scrutiny exists because this specific outbreak exposes a distinct vulnerability in international epidemic readiness. The pathogen driving these infections is the Bundibugyo Ebola virus, or BDBV. Prior to 2026, this rare strain had only emerged twice in recorded history. Biologically, BDBV behaves differently than the more widely known Zaire strain. It replicates at a slower rate and achieves lower peak viral titers, meaning the maximum concentration of the virus inside a host's body is lower. Looking at this comparative matrix, we see the core vulnerability. On the left, the Zaire strain has approved vaccines and rapid diagnostic tests. On the right, the Bundibugyo column is entirely blank. There are 0 licensed vaccines or treatments for this virus. We are not dealing with a novel, hyper-evolved pathogen. We are watching an established virus exploit a void in our pharmaceutical research and development pipeline. Public reaction is often driven by a specific fear, an invisible, airborne pathogen silently spreading through crowded public spaces. Decades of epidemiological data refute this. There is 0 documented evidence of human-to-human transmission of any Ebola virus via airborne microdroplets. Unlike floating respiratory aerosols, Ebola spreads by heavy droplets of highly infectious fluids, like blood or sweat, that fall immediately to surfaces. Infection requires direct mucosal contact with the eyes, nose, or mouth. Furthermore, asymptomatic transmission is impossible. This timeline shows viral load remaining at 0 until symptom onset. It only spikes dramatically after overt sickness, like a high fever, begins. You cannot contract this virus by standing near a healthy-looking person in an airport. Transmission requires direct physical proximity to someone in the midst of a severe biological crisis. If the virus requires intimate contact, why does the outbreak continue growing in the DRC's Ituri province? The answer lies in the environment. This map shows the outbreak's concentration. Red infection clusters overlap heavily with zones of active armed conflict. Because of this, health workers cannot safely navigate these regions to conduct basic contact tracing. Without an approved vaccine, the primary method of containment relies on strict physical isolation. Breaking the chain of transmission requires identifying exposed individuals and safely placing them in dedicated treatment centers before they become contagious. When conflict disrupts that protocol, highly infectious patients remain in the community or are cared for in resource-poor clinics. This creates an extreme occupational hazard for frontline healthcare staff and local burial teams. The virus is thriving because it exists in a fractured geopolitical landscape where standard public health safety protocols cannot be enforced. Knowing how transmission actually works allows us to assess the realistic threat of this outbreak sparking an epidemic within India. Look at this stylized flight map simulating a route from Central Africa to India. International air travel acts as a structurally self-limiting factor for Ebola. Because passengers must be visibly sick to be contagious, their symptoms act as a clear warning, preventing them from flying. Border countermeasures reinforce this biological barrier. Febrile screening, which scans arriving passengers for high temperatures, easily isolates the exact individuals capable of spreading the disease. An intact public health infrastructure and basic border screenings neutralize the pathogen's primary method of spread. A widespread domestic outbreak in India is highly improbable. The global response to the pharmaceutical gap has been rapid. On June 1st, the Coalition for Epidemic Preparedness Innovations injected $61.8 million to fast-track 3 targeted Bundibugyo vaccines into clinical trials. Even without those targeted treatments today, early supportive care and fluid hydration have kept the current 17% fatality rate notably lower than historical Bundibugyo averages of 30 to 50%. The lack of cross-protection from existing Zaire vaccines leaves T isolations vulnerable to rarer strains, but closing that gap is a logistical and scientific challenge we have the tools to solve. The 2026 outbreak is a localized tragedy, compounded by a lack of targeted medicine and conflict. It is not an airborne global pandemic. The risk to countries like India remains exceptionally low, provided the international community commits to closing the gaps in our medical research.